The NHS doesn't need more pilots. It doesn't need another therapy sitting on the shelf. What it needs is innovation that plugs directly into its biggest priorities, freeing up beds, reducing pressure on staff, and cutting long-term costs. I've sat in many meetings at various levels where pilots get applause, but they never get scaled because they didn't tie back to the system's real pain points. When it comes to wound healing, that's not just possible, it's actually within reach. In this video, I'll share 10 steps NHS leaders can take right now to align wound care with national goals and make meaningful change actually stick. Too many innovations get stuck in pilot mode, not because they don't work, but because they don't connect with what drives NHS decisions. Early on, I made this mistake myself. I pitched healing rates when the leadership, who are actually making the decision, only cared about capacity and budgets. The NHS has already shown what's possible. In its mid-year review, it went from a predicted £6 billion deficit to a balance by 5 months, while still improving elective and cancer waiting times. That happened because leaders focused, aligned, and delivered. The same discipline needs to be applied to wound care. 10 steps. Step 1, bed days are currency. Bed occupancy is the NHS's single biggest constraint. Every extra day adds pressure the system can't afford. Frame wound healing in bed days saved. That's the language leadership listens to. I've had countless leadership say, don't show me healing rates, show me freed beds. That changes everything. Step 2, the shift of care from the hospital to the home. The 10-year plan is clear. Care must move from hospital to home. Wound healing fits perfectly here, but only if therapies are safe, effective, and actually scalable in the community setting. I've seen patients heal at home, free up beds, cut readmissions, and that is a real win. Step 3, workforce release matters as much as outcomes. Healing rates are good, but nursing time is better. Faster healing means fewer visits. That's time handed back to an overstretched workforce. Workforce release is now as critical as outcomes. In one particular project, the way they tracked the hours saved with district nursing got them way more excited than any clinical metric. So it is important that we tie these things back to workforce release. Step 4, integrate prevention. Stopping ulcers before they spiral saves money, time, and lives, and is massively neglected. Prevention is not a bolt-on. It has to be built into the pathways. And I have seen personally many times the difference one prevented DFU makes, months of avoided care and thousands saved. Integrating prevention is an absolute must. Step 5, build procurement-ready cases, not pilots. NHS leaders are done with endless trials. They want turnkey adoption, evidence, cost models, supply chain access ready to go. I've heard it so many times. Don't give us another pilot. Give us something. Give us a case that we can buy. Step 6, link every outcome to a pound value. CFOs don't buy healing rates. They buy budget protection. Every avoided admission, every amputation prevented, every clinic visit reduced has a pound value. Translate clinical wins into financial terms. One initiative only engaged with us when I showed the savings on the amputations avoided. That totally flipped the conversation with leadership, and conversations started to happen in a positive way. Step 7, use value-based procurement language. The NHS is shifting from cheapest unit price to best value per pound. Your value stack must cover faster healing, fewer admissions, staff release, and better outcomes. Finance leaders no longer ask what's the cheapest. They ask what delivers the most value, tied in to their key priorities. Step number 8, Harness real-world evidence, not just RCTs. RCTs matter, but real-world data is what convince. Pair gold standard trials with local case studies. That's what builds trust. And I've seen therapies with strong RCTs fail and others succeed because they showed great local results. Step 9, scale through ICS, not just trust. Trust level adoption is slow. ICS decisions stick. Frame wound healing as a system-wide challenge. Capacity, backlogs, amputations avoided. Build a business case at ICS level. I've worked with trusts that loved the therapy but couldn't scale without the ICS giving its backing. Step 10, make change easy, not just obvious. The barrier isn't evidence, it's inertia or fear of workload. Provide full adoption support, criteria, training, logistics, supply chain. If change feels heavy, it's not going to stick. I've seen great data ignored because teams thought it meant more work. Ultimately, simplicity wins. So, the NHS has shown it can deliver 6 billion turnaround in 5 months. Proves it. The same focus must now be applied to wound care. Therapies that succeed won't be the ones shouting the loudest. They will be the ones aligned to system priorities, backed by evidence and packaged for adoption. This isn't about faith, it's about action, building new ways, hitting targets and moving the system forward. The question isn't if wound healing can deliver, because it can. The question is which leaders will take these steps and scale it.